Hello, this is Dr. Lara Tigler. Welcome to my channel. Today I have the distinct honor and privilege to introduce Dr. Todd Teigeler. Welcome.
Thank you. Nice to be here.
Dr. Tigler is an MD. He's a fellow of the American College of Cardiology. He is board certified in internal medicine, cardiology, and comprehensive echocardiography and clinic cardiac electrophysiology. He has performed 1,000 device insertions and has performed at least 500 atrial fibrillation ablation procedures, which we talked about in my first video about atrial fibrillation, which I encourage you to go back and review. Currently, he is in private practice and he is the medical director of the Pacemaker Defibrillator Clinic. Welcome.
Thank you. Thank you.
So I know you've had an opportunity to see the first video on atrial fibrillation. So I'm just so excited that I have an expert in atrial fibrillation so you can fill in the gaps and broaden and give more depth to the information that I already gave the viewer.
Yeah, so I think it was a great introduction, and I think a lot of the important things about the epidemiology, who gets it, what you can do to prevent it, I think you did a great job explaining. So I think you ended that one talking about how there are some procedures that you can do to try and treat the atrial fibrillation. And I think we can go through some pictures and try and talk about what that is. And I think that would be a cool place to continue your first presentation.
Sounds perfect.
So I'm going to share some pictures. All right, can you see my screen?
Yes.
Sure. So, all right. So just to start out, so this is the heart, the way an electrician would think about it. So the electrical system of the heart is in green. And so the normal way that the heart beats is that there's an impulse that starts up here in this thing called the sinus node, or the sinoatrial node up there. That thing depolarizes about 60 to 100 times a minute when you are at rest. It gives electrical activation to the top chambers of the heart called the atria. All right. And so these atria then contract, they beat, so that blood goes from the top chambers of the heart down to the bottom chambers called the ventricles. The electrical activation gets down really quick to this green bean here. It's called the AV node. It delays a fraction of a second there, gives time for the blood to flow down, and then the electrical activation catches up really fast down this special conduction system, makes the bottom chambers contract so that blood can go out this way, up to the brain, down to the toes, and everywhere in between. Okay, so you're supposed to have an orderly way to conduct 1, 2, 1, 2, 1, 2. So top chambers, bottom chambers, atria, ventricles contract, and it's supposed to do what we all know it was supposed to do. So if you're relaxed, it goes to a slower rate. If you're excited, it goes faster. If you're trying to get an A in gym class and run a mile in 6 minutes, it's supposed to go even faster. So that's in contrast to what atrial fibrillation does. And so in this cartoon, if you can see the red arrows on the right cartoon, there are a bunch of different wavelets of activation electrically going every which way. All right. So if you like modeling chaos and random motion with mathematics and fancy computers, that would be about it. So it's literally random motion, and the different parts of the atria are activated at different times, all at the same time, randomly. Okay. And so part of the atria is probably trying to beat 300 or 400 times a minute, and it can't do that. And one of the important things about this AV node, it's in yellow in the middle of this cartoon here, is that it slows down the electrical activation so that the bottom chambers of the heart don't also try and beat 400 beats a minute. So that would be a life-threatening, potentially deadly heart rhythm if your heart rate actually did go to 400 beats a minute. Okay, so top chamber of the heart going at 400 beats a minute is a small problem. Bottom chambers of the heart going at 400 beats a minute, life-threatening problem. Okay, and so what can happen for a lot of folks is that these different arrows here can run into each other. So this one over here can run into another one in the left atrium, and then this other one in the right atrium can run into a valve, and they can all extinguish each other. And you can go back and forth between the normal rhythm on the left side and atrial fibrillation. All right. So we call that being paroxysmal in AFib, or having paroxysmal atrial fibrillation. And that's what a lot of people do. All right. If you can have really slow, sick conduction from, bad atria, these different wavelets can keep on propagating around and never terminate. And so it's possible that you could get stuck in AFib. And that's kind of the natural history, is that as you go and put down more scar tissue, as the heart gets used to being in AFib, the conduction slows and you spend more time, more frequently in AFib, and you progress from paroxysmal AFib, coming and going, to persistent AFib, or just being stuck there. All right. So that's AFib. That's what it looks like in a cartoon. And that's a little bit different from this thing called atrial flutter. So what probably 95% of people do when they go into atrial flutter is a more finite defined short circuit, usually around this tricuspid valve here. And so it's atrial flutter. It's still not the normal rhythm, but it is more organized. It's not the totally random, chaotic motion of atrial fibrillation. And so it's different. We'll just leave it at that. So all the stuff that Dr. Laura Tigler said was true about what you can do medically for AFib. This is the procedure. So this is the ablation. If you wanted to try and get a procedure to try and treat the main causes of atrial fibrillation, this is what it looks like. So if you start all the way over here on the left, this is the heart, and there are hearts made out of heart muscle cells, and they beat and pump and contract, and they also conduct electricity, right? Over here in this left atrium, you see this cartoon has 4 pulmonary veins that bring red oxygen-rich blood back from the lungs. And for some reason I haven't figured out yet, God decided that there should be this, thin sleeve of muscle that grows from the heart down the vein, maybe an inch or two. That's very thin, very weak, and very irritable, and is the main initiator of atrial fibrillation. So the electrical potentials out here in the pulmonary vein sleeves is what we've kind of figured out over the past 30 years to be the main driver anatomically of AFib. And so the goal of the standard AFib ablation is to isolate the pulmonary veins and then look for some other triggers while you're there. And as a procedure, pretty much everyone in the United States puts patients under general anesthesia. So you come into the hospital, the anesthesiologist knocks you totally out, usually has to put in that breathing tube. It's kind of the same setup for taking out your appendix. Okay, so not like the twilight sedation most folks get for doing a colonoscopy. Like I said, it would be kind of taking out your gallbladder level of surgery. So then you start IVs at the top of the leg. You go up to the heart with wires, and the veins actually lead to this right atrium. So the venous system drains into the right atrium via the inferior vena cava. You then have to get the catheters from the right atrium to the left atrium. And turns out the best way to do that is by poking a hole across this wall here called the interatrial septum to go transeptal and map and ablate the left atrium. And so from there are a couple different ways to do an ablation. Okay, and so this left picture and middle picture has what's been around the longest. And so that has a catheter with a metal tip that gets real hot, and you can cauterize, burn, sear, or ablate point by point around those pulmonary veins to isolate the electrical activation, to keep the wonky electrical activation from the pulmonary veins from coming out to the rest of the heart and throwing you off into AFib. Okay, so that's radio frequency ablation. Some people say cauterizing, some people say burning. That's the one that's been around the longest. All right. More recently, on the right side here in the bottom, there are different catheters. This one here sends high output electrical discharges, and that actually depolarizes the membranes of the muscle cells. And if you depolarize the membranes that way, you actually form small holes in the membranes of each cell, and then that throws off all of the concentration gradients that they have, and the cell will actually then die by programmed cell death or apoptosis. Okay, and so either way, you're trying to kill the cells that conduct electricity so that they do not conduct electricity anymore. Okay, and so this one here is relatively newer. It was in research for over a decade, and is really kind of been mainstream for over a year now in the United States. So it's called pulse field ablation or electroporation. Both of them are called ablations. Okay. Turns out it's a really exciting time in electrophysiology. Everybody decided that this is the right way to do it. There are a bunch of different catheters. Each company has kind of made their own. You can send these pulse field ablation therapies via a bunch of different shapes. It's a really cool time in the field. So what we did at my hospital this month wasn't what we did 3 months ago, and was a whole bunch different from what we did a year and a half ago, which is really neat. So I think as far as the procedure, most of the time doing this ablation takes probably about 2 hours, if that's all you're doing is isolating the pulmonary veins. If it looks like there are other irritable or scarred areas that take longer to treat, it can be longer. If you have an atrial flutter or two that you also have to treat while you're there, the time can go up quite a bit. What are the risks and benefits of doing the procedure? Okay, so I think the benefits of the procedure is that it's the most effective way to treat AFib that we have. Okay, and so a lot of the trials, if they take your better candidates, so people who have been paroxysmal in AFib, all right, so they have AFib that comes and goes, their left atrium's not severely dilated, and they don't have big problems like horribly uncontrolled blood pressure or terrible sleep apnea that's not treated. We think we can take those good candidates through this procedure and follow them for years and years and see absolutely zero atrial fibrillation about 75-80% of the time. Okay. And so 75-80% of the time is 75-80% of the time. So it's not 99.999% successful, like trying to take out an appendix, right? So if a surgeon goes in looking for appendix, they probably find it 99% of the time. This treats the main triggers, and there are some risks from the procedure. We think it's probably about 2% risk of complication. So there's risk from anesthesia. You have to start IVs in the femoral veins, so the veins kind of at the top of the leg and in the groin area. The chance of damaging a pulmonary vein requiring surgery to fix is less than 1%. Going up, working in the heart, and if you can see this on the left side of the screen, doing that transeptal puncture and moving around the heart with catheters and doing ablations, we think that having bleeding around the heart, that's a problem, is probably about 1%. Risk of something else like heart attack, stroke, or death is less than 1%. If you are looking at other complications like risk of collateral damage, there are things around the heart that you have to be a little bit aware of. So in this bottom right picture, you can see there's this tube that goes down the middle. So that's the esophagus or the food tube. And it really doesn't have any function to do with the heart, but they are just neighbors in the chest. Okay. And so if you are doing the burning way, or also the freezing way, which I didn't talk about, that not a lot of people are doing as much anymore. If you do that, you can actually damage the esophagus. We think that the chance of damaging the esophagus to a dangerous degree is probably less than 0.1% with the old burning way. After hundreds of thousands of cases with the pulse field ablation, I don't know of any reported case of meaningful damage to the esophagus with pulse field ablation. Okay, so as far as I know, it's never happened. There's also a phrenic nerve Okay, so there's a nerve that runs on either half of the heart. So there's a right phrenic nerve and a left phrenic nerve, and they innervate each half the diaphragm breathing muscle. Okay, the one on the right goes a little bit close to the superior vena cava and this right superior pulmonary vein. Um, so there's a chance of damaging that. If you do ding the nerve, 90% of the time it makes a full recovery. If you were doing the old burning way, there was a less than 1% chance that you ding it and it doesn't recover all the way. And so if you damage that nerve, half the diaphragm wouldn't move so well, and you could have shortness of breath from that. That, as far as we know, also very, very rare, if not never happened with pulse field ablation. So if there's an incidence of it, it's much, 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 much lower, not really measurable after hundreds of thousands of cases across the globe. So because of the safety profile, we think a lot of people are moving towards this newer way of doing it, this pulse field ablation way. And that's because it makes two of our complications much lower. And there's also, as far as we know, no incidence of scarring down a pulmonary vein and causing pulmonary vein stenosis with this pulse field ablation. So that's the procedure. Like I said, it's the best treatment that there is. Who needs to do it? All right. So what's the good indications to do it? All right. And so this comes from the updated 2023 guidelines for atrial fibrillation. And so there are a couple different things that you have to do to make sure AFib doesn't kill you. Okay. So Dr. Laura Tigler talked last time about the increased stroke risk associated with atrial fibrillation. And so you have to make sure that you've considered the stroke risk. A lot of people wind up being prescribed blood thinners to mitigate that risk. And then atrial fibrillation. So, that cartoon that we went over the first time that said that this sinus node, this God-given pacemaker, was supposed to make the heart go, slower when you're resting, isn't really in control anymore. And so it is possible that you could just average a heart rate of 120, 150 at rest. And if you do that for a while, that can weaken the heart and put you into heart failure. Okay. So the bare bones minimum that, we have to do for patients, and patients have to make sure that they do, is that make sure that they are protected from stroke and make sure that they are at least having rate control. So even if you are irregular in atrial fibrillation, you cannot be averaging too fast for too long that you wind up in heart failure. Right? I don't know if we have an exact cutoff for what that number is. It looks my gut sense is that it's different for different people. Some people seem to tolerate 110 beats a minute all the time and seem to do fine. Other people have average heart rates of 90 or 100, and it's caused them problems. So you can't go too fast for too long. So what we call that is rate control. All right. So even if you're in AFib, don't go ridiculously fast for too long. And that's over on the left side of this screen. The right side is rhythm control, which is trying to get you out of AFib and keep you out of AFib. All right. And so just kind of going down what they've enumerated. So the patient choice. So if the patient feels better, so the patient wants rhythm control and this symptom burden, a lot of people don't feel good in AFib. So I think I've heard every story that there is yet. So I think, I have old people who are completely floored by atrial fibrillation. One person went through surgery for a severe mitral valve. So one of the heart valves was leaking severely badly, and he went through surgery for that, and he felt much better. After going through the surgery, he then had atrial fibrillation, and his AFib made it so that he felt as bad as he did with a severely leaking, life-threateningly bad valve. So that guy felt absolutely terrible. Some people hospitalized, some people passed out. Other people have no idea. And so if you're if you have no idea, you can, chop wood, you can go on your, 2 or 3 mile run and honestly have no change in your symptoms and your performance. Well, I think if you're not going so fast that you wind up in heart failure and you're protected from stroke, well, I think you're not doing that badly. All right. So what that says is that favors, if you have fewer symptoms or no symptoms, that favors rate control. Okay. Um, People who have many, many years to live in atrial fibrillation, you probably have a better reason to try and get them out and keep them out of AFib. All right. So if you have been in AFib for a long time, our therapies are not as successful. Okay. So I told you our best case scenario was a paroxysmal patient who's otherwise pretty well taken care of. All right. So if you've been persistently in atrial fibrillation for 2 years and still have a BMI that's very high, have untreated sleep apnea, going on binge drinking episodes every other weekend, yeah, the chance that you stay out of atrial fibrillation is probably less than 20%. Okay. So taking you through a procedure to fix something and your success rate's 20% and your complication rate's still a couple percent, I just don't think the risk benefits in favor of doing invasive procedures in that case. All right. So going down the line, so if you can be put on a little bit of a medicine like metoprolol or diltiazem that literally millions of Americans are on and are dirt cheap, and you feel fine, you know, so if you're easily rate controlled and you're just sitting there at a heart rate of 60, 70 beats a minute and doing fine, favors rate control. If you're taking big doses of these medicines and the doses that are required to control your heart rate are making you feel bad, that favors rhythm control, so getting you out of AFib. If your left atrium, so that chamber that where those pulmonary veins are, if it is severely dilated, our success rates are lower. Okay, and so it's a bit of a long chapter in a long book, but the left atrium, um, I showed you how those wavelets kind of run around, and you kind of want them to kind of hit each other and extinguish, and those patients do better on their own, and they do even better with treatment. If you have a severely enlarged left atrium, you have more potential for problems and more potential to have bad conduction. So our success rates for those folks, keeping them out of atrial fibrillation, are lower. All right. This LV function in AF, so left ventricular function, so the big, strong, important pumping chamber of the heart, if that's not doing too well at baseline, if you have a weak heart already, and then you throw in the insult of atrial fibrillation, those people don't do as bad as well. So if you already have a mildly reduced heart function, there is those people benefit more from ablations and treatments to get them out of AFib, keep them out of AFib. All right, and so this other thing here, this AV regurgitation, so atrial ventricular valves, so the tricuspid valve and the mitral valve. Sorry. So this valve here, I'll show you this one. So this valve here and this valve here, okay? So this tricuspid valve and this mitral valve, they're the valves between the top and bottom chambers on the left side and the right side. And if the atria never really contract and empty, so that blood goes down and you flow well, they fibrillate, they kind of dilate, and they dilate over time. That's potentially reversible if you intervene on it. If you let it keep going and keep going and going, it can stretch that ring on the bottom of it that holds the valve, and that ring, that the annulus for the tricuspid and mitral valves, can pull apart, and the valves that insert there can actually kind of pull apart, and they don't meet in the middle. All right, so blood can leak backwards, and so you can have mitral regurgitation or leaking across the mitral valve, tricuspid regurgitation, that can happen as a result of atrial fibrillation. And so if in sinus rhythm you have almost no regurgitation, well, you're okay. If in AFib you have a lot, well, that probably makes an argument that you should go through this procedure. Okay, so that's kind of where it is. They didn't put age and so like frailty up here, but I think in general, this is a couple hours under general anesthesia. I think you should be ambulatory. I think you should probably be able to hopefully get up a flight of stairs. I do think we've gotten much, much safer over years at doing the procedure, but I think there's a certain amount of robustness that you should have before signing up for the procedure. That's the ablation. That's kind of some pictures of the catheters out there. The kind of what you had introduced last presentation was this whole stroke risk in AFib. All right, and so what we do is if you've got atrial fibrillation, we kind of put you into a calculator to decide what your risk of stroke is. So we add some different factors of who you are, and we try and estimate what your risk of stroke is per year. And so a lot of times that comes out with a recommendation that you should be on a blood thinner. And this is why. So if this pouch here, this is the left atrial appendage, it was a structure that was probably very important when we were all, a developing baby in the womb. And then it stayed small, and the rest of the left atrium kind of grew around it. And it doesn't appear to have much helpful function, but it's this blind pouch, okay? And if it's trying to beat at 400 beats a minute, well, it doesn't actually empty, it just kind of quivers or fibrillates. Well, that's where the name atrial fibrillation came from. The heart looks like it's just fibrillating. And if you do that, blood can swirl and pool, and blood that swirls and pools is apt to form clots, okay? And so that's where the stroke risk comes in from atrial fibrillation. If you're somebody who is at a risk of having a problem from blood thinners, but you still don't want clots to form in the left atrial appendage, sometimes we talk about procedures to plug the left atrial appendage, okay? And so this is a different invasive procedure, so same kind of setup. People go under general anesthesia usually, so most people do that. IV in the leg, go up to the heart with the wire. You still have to go across the septum here. And then you have this wire attached to this plug. This is one of the older versions, but you can plug up this pouch, and then if a clot forms over here, it doesn't go out to the rest of the heart and throw you off into AFib. All right. So this is what it looks like. This is what it looks like in the pouch. And then if you look down the barrel in this picture, you can actually see that hopefully everything is nice and well sealed. And then after weeks to months, the heart grows a layer of cells over it and incorporates it into the wall of the heart. So there are a couple different occlusion devices out there, a couple different ways to do it. The one that's used most is this thing called the Watchman device. There's an amulet device. The surgeons do it via open chest surgery if they're there for bypass surgery or something, but this is probably the one that's done most. Okay. A bit of the catch 22 for doing this is that while you're still growing that layer of cells over the device, you don't want a clot to form on it, being recognized as a foreign body and being a cause for clot and stroke. So in these patients who you don't want to be on blood thinners, you have to have them on blood thinners for a while until this thing gets incorporated into the wall. So that's a consideration. And then there are some people who have a bunch of problems with going too fast in AFib. All right. And so some people go ridiculously fast in AFib, and then you put them on a bit of these medicines to slow the heart rate down. And when you do, the regular heart rate for some folks is, it starts at 50 beats a minute on the slower side. And then after you drug them, the borderline low heart rate can go low, and people often feel badly with that. And so those patients kind of have their option of going too fast or too slow. And so you kind of want them in a healthy range at least at rest. And that isn't always something that we can do with medicines. And if you're not a good candidate for the ablation, or you were in one of those people who we did it and we didn't have that much success, or if, I said you should have some amount of robustness to probably go through the procedure. If you're not that robust, a lot of times people wind up with a pacemaker. All right. And so this pacemaker device, the standard traditional one, has wires that go, you make an incision here, wires go down to the heart. Couple wires can do that. Usually one in the bottom chamber, one in the top chamber, sometimes a third one to pace the other ventricle. And then the pacemaker, the only thing that does is it helps keep the heart from going too slow. Okay. And so you can be programmed to not go below a heart rate of, say, 60 beats a minute, 50 beats a minute, 70 beats a minute. Pick your choice. And so that protects you from going too slow. It doesn't do anything to keep you out of atrial fibrillation, right? So if you were in atrial fibrillation going at 150 beats a minute, feeling terrible, and someone magically snapped their fingers and, put in a pacemaker, the pacemaker would watch you go 150 beats a minute in atrial fibrillation, okay? So it doesn't keep you out of AFib, doesn't keep you from going too fast in AFib. It allows people to use a bunch of medicines to keep you from going too fast while protecting you from going too slow. And if, despite our best juggling of medications, we can't do that, there's kind of one last ablation that we can do, which is one wire goes up to the heart. And on this cartoon again, the conduction system, you can actually burn the electrical connection between the top and bottom chambers. So if you burn the AV node and an AV node ablation, the top chambers of the heart can still be trying to go 400, 500 beats a minute, but the bottom chambers are not under their control. So it's just paced along by the pacemaker. All right. So that's kind of the last ditch effort of what to do for folks who really don't have any other options. You put in a pacemaker and then you ablate the connection between the top and bottom chambers electrically. And then they're just paced along by the pacemaker. And that's kind of what it is. So those are kind of some more pictures of the treatments that are out there. I think everything that you've said last time is true. So what you can do to not have AFib in what your ounce of prevention kind of things. You said all of them already. So try and have a good healthy BMI. Try to do some amount of exercise. The updated guidelines, they actually made it kind of hard to follow. It's tough. So it's probably about 210 minutes of activity a week. So actually, that's hard to do. It is. I think generally, if you shoot for half an hour a day and life happens a time or two a week, you're going to be close. I think you get a lot of health benefits from doing purposeful physical activity and exercise anyway, even if you don't make 210 minutes a week. I think there's a big focus on sleep apnea. And so how everybody likes antioxidants. So there's the changes that happen in the body while you're not breathing overnight are the opposite of an antioxidant. It's an oxidative stressor. And so the oxygen level in the lungs go down, the blood pressure in the lung arteries goes up. The cells of the heart use kind of the wrong molecules for energy. And the cells that are there, they actually put down the wrong tissue. So there's the muscle cells of the heart, which are the most common. Then there are also these other cells that put down the connective tissue that kind of glues it all together. Your muscle cells can actually transition to look more like those connective tissue cells, and they put down more scar tissue, which further slows the conduction electrically through the heart. All right. And so all of those things are more likely when you are hypoxic and not breathing at night. And so if you were to go through some of the trials, and if you had significant untreated sleep apnea and you went through an ablation, your chance of staying out of AFib is actually cut in half because of the sleep apnea, which is, in my point of view, quite striking that you can go through an AFib procedure and for a non-cardiac stressor have your success rates affected by essentially twofold, which is a big deal.
So,
So sleep,
Dr.
sleep,
Tigler, I'm going to have to interrupt you just because this video is going a little long.
sure.
But I am so grateful to you for all of the information. And I love that you showed these graphs and pictures because you just gave us so much information. And I'm pretty confident that the viewer is going to have to replay this video twice, thrice, maybe multiple times. And then they'll be able to use the pictures to know where they can go back and kind of replay certain information that they need to hear again. I just had a couple questions for you mentioned that the risk of death, I believe it was less than 1% for the pulse field ablation treatment. Is that correct? Is it less than 1%?
Yeah, so your chance of having, so going through ablation either way, so with pulse field ablation or radio frequency ablation, either way, your chance of having a heart attack or stroke or death, lump them all together, is less than 1% during the procedure.
Perfect, because I couldn't quite remember if I heard you say that there was a risk of death with the radio frequency type, but now you say it's the same risk for both procedures.
Yeah, that's probably true. So the you still have to get a wire there, okay? And so the energy that you deliver is different, but you still have to get IVs in the leg. You still have to get up to the heart. You still have to do the transeptal puncture. So, and you'll still have a catheter in the bloodstream that's upstream from the heart and the brain. Okay, so if a small air bubble goes off or a small clot forms on the catheter, that can go flick off and go to the heart or brain to cause heart attack or stroke. Okay, um, that should be less than 1%. And then if you have bleeding around the heart, that makes it so that a dangerous situation happens. That's probably where the risk of death is, but that is also less than 1%.
Okay, and my second and final question, because there's so much information, and like I said, I'm pretty sure the viewer's going to have to replay it, but are all the pictures you showed us, that last picture you showed us clearly said that when we were looking at the picture, then the atria that we saw on the left was really the patient's right side. Like you can see with this picture here, it does say, I just wanted to orient the patient that
Sure. Yeah.
every single
So
picture you showed, we're actually looking at the patient face to face, right?
that's correct. Yeah. So this is someone looking at you. And so if you can see my cursor here, this one that says right atrium, if someone's looking at you, this would be kind of their right arm, head, feet, right arm, left arm.
Perfect, because that's going to really help a patient orient or a viewer orient to
Yeah.
understand it. Is there anything that you want to say in closing that you feel is important for the information given in this particular video?
No, I think if you have viewers or just your patients and don't actually have atrial fibrillation, but we're bored one night, what can you do to not go into AFib? And that's kind of ounce of prevention kind of stuff. And that's the diet and the exercise, and they actually took out the caffeine restriction. So we don't think a cup of coffee a day is going to do anything for your AFib um, risks. Alcohol, on the other hand, kind of, we got more data that probably is a bigger risk factor than we thought. So I know a couple of guys who, so in practice cardiologist in his 40s, who's a tall guy, and ever since he was a student, he would have, if he had a beer or two, he would go into AFib and felt absolutely awful. And he's a pretty healthy guy, tall, kind of lanky, kind of goofy guy, but he just doesn't drink anymore because his risks of going into AFib are so high.
Oh, yeah.
And there's a study I think published about a year and a half ago, and they followed people with very invasive monitoring and looked at it very carefully. And if you have a drink of alcohol, your risk of going into atrial fibrillation over the next 8 hours or so is probably double. So if you had a 2% risk of going into AFib any one day, that went up to 4%. And if you went and had 2 drinks, that risk probably tripled. So some people, you're more likely to be sensitive to be driven into this by alcohol than you are a cup of tea. So
Yeah, on that sad note, let's end. Sorry, viewers. I'm so sorry to have you heard that, but that's what us
sure.
doctors do. We give you that kind of news, don't we, Doc?
Yeah, 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 yeah. So
Yeah. And I hope, thank you, viewers, for reaching the end with Dr. Tigler and I. And then I hope to have you back so we can break this down and maybe make a shorter video with maybe just talking about just one procedure.
sure.
But that would be so great because the information you gave us was truly very important and very enlightening. And I just thank you so much for joining me today.
Yeah. And thanks for the work you do on your channel. A lot of good stuff.
Thank you so
So,
much. Have a good day.
all right, you too. Bye bye.
See you next time.